I like how these themes are starting to develop over the course of the day. We're going to talk a little bit about telehealth. We've talked about this panel is supposed to be about personalized medicine. All of you have technologies, tools, and techniques for creating that personal and delivering that personalized medicine. But making sense of the data is going to be another theme throughout the day. So I think this is a great, we're starting to see where we're going with this and where things are. Before we get started, maybe just talk a little bit about your background and sort of your approach to personalized medicine.
You want me to start?
Yeah, we'll start with you.
Okay. Well, first say I'm Nina Crowley. I'm a registered dietitian and a health psychologist, and I actually go by psychodietitian. So not a.
Oh, that's such a
I
good
forget
title.
the other term, but that's mine. There's only a few of us. I work for seca, a company that is a 185-year-old German company that makes scales and weighing and measuring equipment. So my daughter was weighed on a seca, I found out once I started working for them. They also make body composition equipment, and that's the area that I do. So we measure through bioimpedance technology, which has been around a long time. It's gotten a lot better over the years. We measure the muscle mass, fat mass, and the different components of someone's body. So we'll talk a lot about how that kind of is that behavioral piece that we actually do have to do still without technology. We have to do all those things, and I think our technology can make that easier.
And I'm going to follow up with asking about what that body composition really means individually. But we'll get to that in a second.
Okay.
Gil?
Yeah, I'm a scientist in background, a longevity seeker from a very young age. And I'm the founder of InsideTracker. InsideTracker is a personalized nutrition, personal health company that helping humans to optimize their body based on a lot of data. So we are collecting around 50 blood biomarkers, and we are sampling your DNA. We are connecting to a fitness tracker. We are looking at how you consume your diet in a week. All of that allow us to build a sort of a digital twin of your body, and based on that, providing to you recommendation what food to eat, what supplement to take, what exercise to do, what lifestyle changes to perform. And those recommendations come from a peer-reviewed scientific publication, so we have a big team of scientists that extract the data. We have hundreds of thousands of users, and we are lucky enough that we had the chance to publish it in a peer-reviewed scientific publication and show that a lot of our users improved their key biomarkers that clinicians will use, like cholesterol and glucose and testosterone and inflammation and all of those from baseline to follow-up. Again, it's just a correlation, it's not a causation, but we have a very nice data about that we published and we are publishing, and very excited to discuss it today.
Gil?
And Andy Molnar, I focus on patient access to innovative technologies. So I have a really easy job, right? That's all. Specifically focusing on coding, coverage, and reimbursement for software as a medical device or digital therapeutics. I was the CEO of the Digital Therapeutics Alliance for 4 years. We were just acquired by the American Telehealth Association. We focus on additional areas like the same issues with digital therapeutics apply to digital diagnostics, to artificial intelligence, and to many of the products that you all have been talking about. And I do that through a policy lens, through a regulatory lens. I'm also on the FDA's Digital Health Advisory Committee as an alternate industry representative, so I'm a low on end of the totem pole of Ami's coalition that she runs down there.
So you're trying to solve that coding problem that we talked about earlier today and have these treatments actually paid for.
Yes.
So what are some of the treatments you would most like to get paid for that would make the biggest difference in people's lives?
Oh, well, I mean, God, there's so many of them. But I think, a really big win that we had last year was in the physician fee schedule for coverage of digital mental health treatment devices. That's what CMS called them. So software as a medical device does not have a clear way to get paid for. When Medicare was founded in 1965 or started in 1965, they thought everything happened within the four walls of the doctor's office. And unfortunately, the program is still designed for that. And so we have been we've put legislation forward, but we've been working on so many different ways to get these products in the hands of patients. And CMS finally said, we have a way for physicians to prescribe these mental health devices. Mental health is like a very, very clear application for software and making a profound difference. And this is substance use disorder, major depressive disorder, insomnia, and women's health as well, all covered under these codes, and they need to be expanded and they need to cover more.
Let's go back to that body composition and why it matters.
Okay.
I have a very smart scale that tells me all sorts of information. We talked about how often I should get on that scale. It's in my home. Seca's obviously working at a different level and providing a different granularity of data, but why does it matter? Why do people need that? And what does it tell you about how to deliver personal care?
We have so much to talk about, too much technology. But I think one of the big things, I loved the way someone framed this earlier about the blood pressure cuff, right? We could all have the same blood pressure, but have so many different things going on in the body. I think about that with weight and BMI. And actually, I'm very, kind of overwhelmed by the fact that of all the technology that we have and interesting things I've even just heard today, we're still in healthcare just looking at weight and BMI across the board. We're still basing, surgical and medical treatments based on someone's BMI. We have technology to do better, and so from the bioimpedance side, you have it in a clinic. It looks like a scale. You step on it without shoes and socks, and you hold sensors, and it measures, the flow of this low-dose electrical current through your body tissues. And so that's a really easy, quick way to give someone much more insight. And so with women's health and with all the different things that we have going on now, we really want to look at visceral fat rather than just total body fat. We want to look at, with frailty and aging and all of that, skeletal muscle, not just lean mass, but actual skeletal muscle. And we can do that. We're validated to MRI. So you don't have to go have an MRI. You can go in your clinic and have this done. And so there's a lot of ways.
What would be the cost difference between those two tests, an MRI versus a seca scan?
So with some of the new and, kind of expanded ways people are using MRIs, I think they're in the several $1,000s range to find out all the things you could possibly have wrong with you. That could be a whole nother topic. From a medical sense, if you have something wrong and you're looking at it as a diagnostic, they're usually you're not doing that to look at your body composition. So I don't even know the cost for an average person who's like, I want an MRI for body composition. But this is something, the way that we have it, it's less than a minute and you do it, the doctor pays for it, it's less than $10,000 in a clinic. And it really helps the clinicians be able to connect what they're talking about in practice and what the people have to go do. So, that's the stuff that we're all talking about here, right? You're going home and having to do the efforts, change your diet, move your body. All of those things can't necessarily be done by technology, but we need to look at better ways of talking to people about their efforts. Who loves getting on a scale? Maybe you do, but who loves getting on a scale?
I definitely do not.
Who loves getting on a scale?
Not for a long time, anyway.
Right, and looking at that number. People hate that. And so, we have a better way to show them. Let's get on this device and look at stuff other than that. Maybe your weight's going up, but if your muscle mass is going up, that's the marker we want to look at as we age and get stronger and healthier.
So Gil, it seems like you're creating this incredible dashboard, all these markers. Out of all of that data, what are the things that are most important, and then what actions do your clients take? Like, how do you make it real for them?
Yes, so I think that we discussed it before in different panels that we have too much information and it's very hard to make sense, and the data is not what's important. What is important is the intervention and how can we also explain it to the user what is the most important for them. So in the last decade or so, we worked very hard, including a lot of behavioral science that I heard a lot of discussion today. And in my opinion, that's the next revolution after the AI, because the AI is great, but then how do you communicate it to the user and make them to do something? So we work very hard on doing that. And one tool that we developed called a biological age, we call it inner age, basically combining all those markers together, and then allow the user to compare his chronological age to his biological age, and then he can see whether he's older or younger, how older, how younger. And even so, then drill down into why is he older or younger, what are the markers that make him older and younger, and then drill down even better, even deeper, and try to understand, okay, what intervention can I do in order to become younger? So basically build a loop that first the user, it's easier for him because nobody know what are AST and GGT unless you are a clinician. But then explaining to him, making it in one number, and then allowing him to break it down, and then understand, okay, those are the two interventions that I should do, and hopefully next time my biological age will be a bit better.
We talk about, I remember we did this conference a couple of years ago, right after COVID, and telemedicine was obviously super important on everybody's minds, and regulations had been relaxed, and doctors were practicing remotely. Doctors may not have been happy about it, but they knew the reality, and they had to deal with it, but they were worried it was going to go away. They were worried the rules were going to come back. it seems to me now there's much more acceptance in the medical community that the home is an important place to deliver care, that the data and the sensors that they can do long-term tracking is a useful asset. But I mean, what have you seen as you're down in Washington trying to get these things paid for? The doctors seem like they're on board, the patients seem like they're on board. I don't. Is it getting? It seems like it's still not getting paid for though.
Well, the telehealth extensions from COVID were just signed again. I don't know, last month, what month are we in? I can't remember. And they're going to be up for renewal in September. They continue to
Are they
be
doing it 6 months at a time?
Yeah, it's brutal. I mean, it keeps me employed, which is nice, but but for the patients and for investment to advance it, a lot of companies are out there saying, well, if we don't know if they're going to be around, should we continue this? And what we do know is that the patients like it, right? It is so beneficial in so many ways, not to take away from going into the doctor's office, but even God, my son had pink eye, and I was able to do a telehealth visit and get a prescription in 5 minutes. I mean, it's phenomenal.
With a camera. Like you had the video on, it was like, clearly that is what it is,
Yes.
and I can safely give you this prescription remotely.
Yeah, so we're continuing to work on the extension. So it's really a defensive play. We have to make sure they don't go away. If we can get them extended indefinitely, though, I mean, that's where we really need to be. Virtual care, and not just from a telehealth perspective, but virtual care in general is the future of medicine.
Nina, would you agree with that?
Yeah, absolutely. We're trying to figure out how, we talk a lot about body composition at home. People ask me that all the time. And so, working for a 185-year-old German company, they are really into it being perfect before they get it in the home. For me, as the behavioral kind of voice on the team, I don't know that I want people measuring their body comp at home every day, because they can't even handle the results from a monthly measurement when it comes to how do we take this data and turn it into action rather than just perseverating that, is my muscle really down? Is my fat up? What did I have for dinner? What do I do? I mean, that makes it really hard. So I don't know that that's probably not the company answer, but for me, looking at how does this data actually help people change their behavior, it can be motivating, but it's got to be done right. And so I do think that there's, lots of ways to stay connected to the healthcare team. It may be not that you go get your body comp done in a doctor's office. So I'm really open to actually innovative ideas of where can that be done, but in a way that helps the patient and doesn't harm or make mental health even harder. Because you don't want people, that are on the edge of disordered eating, like looking at that data too much. You don't want people, if you're not there to manage their response, it can be tricky.
Well, I mean, you've said a couple of times in our conversations that this is too much about tech. We're talking too much about tech. There's another aspect of personalization that is often overlooked, and that the tech can often obscure. So maybe make that point and talk about how to personalize healthcare in a way that's not just about providing, biomarker information.
Yeah, I mean, don't get me wrong, I love the technology. I love being able to know the data, but the crazy part is that for the individual, you do have to take all of that and practice it every day, day in and day out. So I think the ways that we can, use it to help design better eating plans, help people move more, get their data to them so that they can see the results, that you're not just working, mindlessly in one direction and then you go see what your weight did. That's a huge place to do that. I think the technology can help the individual, and it can really help the provider get that information and help them make those change. But as the person who did this for a long time with a surgical weight loss population, it's hard work. The patient has to go home and do it, and you might work really hard and not see a lot of change. So we've also got to deal with what happens when the numbers aren't positive or moving in the right direction. What happens if they are not seeing the outcomes that they expect? And we all want to do better, live longer and all of that. And so I think we've got to think how those things can interact for that individual, and then have the healthcare folks, come alongside and help them make that happen.
Got it. So Gil, how do you deal with that sort of personalization of helping people understand the data, like giving them the sheets, giving them the recommendations? Like, how high touch are you in terms of helping them contextualize it and really make sense of it?
Yeah, first I want to add that our healthcare system is reactive, is not proactive, is treating the issues, not preventing them. And I think that that's something that happened with the wellness revolution or the longevity revolution. So you don't need to be sick in order to start manage your health. And one thing that we have done is if you, I'm not sure that you have seen data of a blood test, you have normal range, you are in the normal or out the normal. And if you look at a marker like glucose, it's 65 to 99, doesn't matter if you are young or old, athletic active or a couch potato, male or female and so on. So we develop a optimal zone for each person based on a peer-reviewed scientific publication and based on a big database. And then nobody is optimal. And actually, normal is boring. Optimal is cool. You want to be optimal. You want to be the best that you can be, because if you will be best that you can be today, hopefully you can live to 100 in a good health span and not just lying on the bed and connecting to a lot of tubes. So we are trying to educate our users about that. It's all about prevention. It's like, in a way, we are in the Wells magazine event. It's like 401k. You are starting to save for the 401k, hopefully in the 20s, not at the age of 64. So it's the same here. You need to start working on that. And so that's one point. The other point is you cannot interact with everyone in the same way. There are a different kind of people, and each person also have a different time of the day or the year or the week that is getting into a crossroad. And that's the time that you need to interact with him. And that can be when you receive the blood test and you've seen that I don't know, biological age is too high. A lot of them are really pissed at us. And I love it, actually. A lot of people coming to me and say, oh, I'm older than my chronological age. So I'm saying, oh, that's great. Now you know that you have a problem and start working on that. And a lot of people that worked on that decrease their biological age and become better. So I think that it's a lot about, you don't always need to make the consumer, and we call them consumer, not patient, because they are not sick, our users. You don't always need to make them happy. It's good that sometimes they are pissed and sometimes they are not happy and sometimes they are excited and sometimes they are not. And that's life. You know, we are having ups and downs, and it's not always a shiny or rosy. And I'm not waking up in my age every morning and say, oh, that was my best sleep of my life. No, it's not. And all of you have that, I assume. And we need to find a way, how can we at least delay the decline of our sleep quality and our mental quality and all of that. And that's what we're trying to do, and hopefully we are at least doing some of it.
So we've got a couple minutes left. I want to get something hopeful, something that you're excited about in terms of new technologies, new treatments, new access in ways of delivering healthcare in a more personalized way. Andy, let's start with you.
So the thing I'm most excited about is PADERs. Is that like a normal word yet?
I don't think so.
No, okay. So
not to me.
This is prescription drug use related software. It's kind of more fun to say PADERs than it is to say what the acronym actually stands for. This is a regulatory pathway defined by the FDA. It's still a draft guidance, but it doesn't matter. It sits under existing policy. What this is a way to combine drugs and software to increase the clinical effectiveness or the safety of the drug. And so even though PADERs, just like PDUFA, comes from the FDA, every global conversation I have with pharmaceutical manufacturers, they're interested in this concept. I'll give you an example. Head and neck cancer, terrible. An outcome for a lot of those patients is suicide because it's so painful. The pharmaceutical companies building these solutions to help patients are like, we need to help them with their mental health from the very beginning. So we need software that sits on the label with the drug that can make a clinical claim that has been clinically validated and studied, and we need to get that to the patients. Okay, why is this so exciting? Reimbursement is not an issue because it's covered on the pharmacy benefit. It's not an additional cost to the patient. It's an additional tool that has clinical outcomes. We don't have to worry about reimbursement, and it normalizes digital health for patients. Because like we say, we have the wearables and we're so used to that. And we're so used to mobile health. But as soon as you start saying, oh, I'm going to prescribe you a virtual reality headset to help you deal with your pain, the patient goes, oh, I want pain medication. And you're like, no, you don't want pain medication. This is why that can be, I mean, you probably need some, but like that's why this can be bad. If I give you a virtual reality headset, it's no medication, it's cognitive behavioral therapy, it's long-term outcomes, and that's not normal yet. And so if you're just being prescribed your drug, where you have this digital product along with it, then in 10 years from now, if you're prescribed a virtual reality headset on its own, it feels normal. We're just not there yet. And this is like sort of that bridge. So it excites me for a wide variety of reasons.
That's a very specific example and a fabulous one. Nina, you want maybe the last word?
Sure. For me, I'm excited. We haven't really talked too much yet here about the GLP-1s and that class of medications, but for me in bariatric surgery, which felt like a very other group for 18 years, there was not a lot to talk about publicly about that. The past 3 or 4 years have been really exciting because many more people are interested in what's happening with these possible medications. So the ability for people to have, all sorts of, impact in longevity and weight health and all these other areas that are coming out, pairing that with the responsibility of looking at someone's body composition has been so exciting, because I think that's been the thing that's elevated us to do the thing that's been available and that just has not been standard of practice. So I'm happy to be kind of at the center of that, and that is a real sort of health and wellness converging and being able to help kind of figure out what's next is exciting.
I can't believe we made it this far without GLP-1s being mentioned. I don't know, there's a bingo card somewhere, but we've made it far longer than I thought we would. Everybody, thanks so much for doing this. It was a great conversation.
Thank you.
Thank you.